Welcome, and thank you for joining us today for Applying Pressure to Diagnose Preeclampsia Better and Earlier, part of our Value of Diagnostics within Women's Health series. I'm Dr. Rena Ninye, Chief Science Officer for the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education, while promoting research on sex differences to optimize women's health. Spanning from simple blood tests to x-rays to invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to valuable information to help women make informed decisions about their health across every stage of their lives. As such, SWHR's Value of Diagnostics within Women's Health series highlights the importance of advances in screening and diagnostic technologies and approaches throughout the lifespan, with a focus on how we can improve health outcomes for women. Our theme for the 2025 series is maternal health. And so we are pleased today to have two distinguished panelists joining us for this public forum in recognition of World Heart Day. Dr. Ukachi Emeruwa is an assistant professor of obstetrics, gynecology, and reproductive sciences at the University of California, San Diego School of Medicine. And Dr. Carl Wiener is a professor of obstetrics and gynecology at Creighton University School of Medicine in Phoenix. I would also like to thank the sponsor of today's event, Roche. SWHR maintains independence and editorial control of our program development, content, and work products. And as always, we will be live tweeting during this event and invite you to use the hashtags SWHR Talks Diagnostics, as well as hashtag SWHR Talks Maternal Health on all social media. Preeclampsia is a serious pregnancy complication typically characterized by high blood pressure, protein in the urine, and signs of damage most often to the liver or kidneys. It typically develops after 20 weeks of pregnancy and, if left untreated, can lead to severe outcomes for both mother and baby. While the exact cause is not fully understood, preeclampsia has been linked to problems with placental development and blood vessel function. It remains a leading cause of maternal and infant illness and death worldwide, affecting between 2 and 8% of all pregnancies. Moreover, postpartum preeclampsia occurs in 2 out of 7 pregnancies in the United States. These rates underscore the need and significance of early detection, effective management, and long-term monitoring of women's cardiovascular health during and after pregnancy. Today's public forum will explore the impacts of preeclampsia on women's health and present strategies for integrating screening and monitoring into clinical practice to improve maternal and infant health outcomes. I will now introduce Dr. Emeruwa to talk about the impacts of preeclampsia on women, including disparities in disease burden and preventive care. Thank you for joining us.
Thank you. Let me just start by sharing my screen here. I think we're all set up here now. So like I said, thank you very much. I'm going to jump right in because I feel like we have a lot to cover in a span of 10 minutes. I want to spend the bulk of the time reviewing what really is preeclampsia or hypertensive disorders of pregnancy and really kind of unpack what we understand it to be to set us up to really breeze in a high level overview of the signs and symptoms and the diagnosis and set us up to really understand some of the emerging tools and innovations that you'll probably hear about from Dr. Wiener. So what is preeclampsia? I think a lot of us, when we say it to ourselves or to our patients, will describe it as high blood pressure in pregnancy, plus or minus protein in the urine. But I would challenge us to say that if we start by describing it that way, we are setting ourselves up for failure. We're both setting our patients up for failure in their awareness and ability to detect the signs and symptoms. And ourselves as investigators and clinicians who want to do better for our patients, we're setting ourselves up for failure also with regards to, understanding the next steps in innovation and diagnostics. So I want us to take a step back and, like I said, really unpack what is preeclampsia. So as you briefly heard, what we understand it to be is a placenta problem. And what you have here in this graphic, I don't know if my mouse will show up, is what you have is this bottom half, you have the maternal side, right? So this is the maternal side, the uterus. These schematics are kind of similar. And on the top side, you have the placenta or the fetus side. And so in a normal pregnancy, on the maternal side, the side with the uterus muscle, these arteries connect to the placenta side and they open up and have nice, free-flowing, low-resistance blood that's going from the mom to the baby. And the issue that we think happens in preeclampsia is that these arteries that are supposed to connect to the fetal side, for some reason, don't set up correctly. And they have these tight, narrow passages that create a lot of turbulence and shearing off of cells and factors and inflammation that essentially starts to travel everywhere in the body, right? So you have these inflammatory cells and factors or various proteins that are going to be affecting the mother's kidney, lungs, brain, liver, blood cells, heart and blood vessels, and the fetus and the placenta, right? So I actually make it a point to tell my patients that, you know, sorry, as you can see, blood pressure is just then one of many, many signs of things that can be affected by preeclampsia. So we're really reducing it when we call it high blood pressure in pregnancy. So when I explain it to my patients, I really make a point to say, you may have heard of it as high blood pressure in pregnancy. It's important to level set where people start with their understanding. But really what it is part of a spectrum of conditions where for some reason, the placenta sets up shop incorrectly and releases factors that can really impact almost every system in the body, including the baby. And I say a spectrum of conditions because, again, we use the term preeclampsia, but we throw it around pretty loosely. And I think people really intend it to include all these other terms that are along that same spectrum of conditions. And again, because blood pressure just happens to be one of the things we can detect most easily and, at a low intervention way and tends to be one of the earlier signs, we separate these definitions by blood pressure plus or minus other organs and when they onset in pregnancy. So if we see something happening before 20 weeks or after 6 weeks of delivery, which I'll touch on in a second, we think of it as a non-pregnancy related. Whereas if it happens with blood pressure or other organ things between that 20 and 6 weeks, we think of it as a hypertensive disorder. A quick word on that 20-week and 6-week cutoff. It's still a little arbitrary, but just so you really understand what's happening is, we have an embryo and it divides into many cells, and part of those cells form what's going to be the placenta, and part of them form what's going to be the fetus. And then those cells the placenta has to connect to the mother's uterus and the arteries and grow and grow and grow to form a placental body. So we tend to think of things that are happening before 20 weeks, like chronic hypertension, as something where there's not enough connection between the baby and the mom and not enough placenta that we can think of it as a pregnancy related thing. Whereas after we're like, okay, there's enough placenta mass, there's enough connection that this could be attributed to a placenta issue. And so now you understand why similarly with preeclampsia, which is just adding the organs on, it's similarly after 20 weeks, if we see an effect on the kidneys, we're spilling a lot of protein, the platelets go down, we're shearing a lot of cells, the creatinine goes up, the liver starts malfunctioning, we can start to attribute this to the placenta. And just a word on that, I think when you understand it this way, it makes it really helpful to know why it's important to take the patient, not just as blood pressure plus or minus and organ systems. If someone has a chronic condition whereby, for example, their kidney is affected, their brain, their liver, if someone has a creatinine of 1.1 at 26 weeks, but I didn't know they had chronic kidney disease and their creatinine was 1.1 before pregnancy, I may think it's preeclampsia, but really it's not a placenta issue. This is their baseline health, right? So just a word on why it's really important to take the whole picture of people and not just think of it as a blood pressure thing. And when you understand preeclampsia, that whole picture, whole disease system starts to make more sense. So now that we understand really what preeclampsia is, it walks us right into what we're looking for when we describe the signs and symptoms of preeclampsia. So when we look at the signs, we're looking at things that we can test very easily, right? So in addition to high blood pressure, we can check the urine for protein, we can check the kidneys, the liver function, the platelets, the blood count. And when we describe symptoms to patients, they start to make sense too, right? When you're spilling a lot of protein in your urine, there's not protein in the blood vessels to hold in all the extra fluid that you build up during pregnancy. So that fluid starts to spill into the lower legs, into the lungs, into the brain, into, around the nerves, around the eyes. And now all the signs and symptoms you're telling patients to watch out for make sense, right? So who's at risk for preeclampsia? I have a good friend at Preeclampsia Foundation, Eleni Sigas, who used to joke anyone with a placenta. And as either morbid or silly as that sounds, when you understand what we're talking about, now that makes sense. Truly anyone with a placenta can get preeclampsia. That being the case, of course, there are people who are more or less likely to get it, right? And I won't belabor these high risk and low risk factors for you because we don't have time. But really, it's, anybody whose combination of egg and sperm has genetic material that formed the placenta that could get preeclampsia before. More placenta. Anyone with baseline compromise in any of those organs that could be affected by placenta dysfunction, and a number of other various risk factors that we think can affect people's systems. So, like I said, the foundation is really knowing what preeclampsia is beyond how we traditionally described it. And now we can start to look at what some of the innovations are, right? So instead of trying to determine what preeclampsia is by, risk factors or who we think is more susceptible to respond to the compromise by the placenta, we can start to look at the placenta, right? Like, what are some of those factors in the placenta that are circulating that are telling us preeclampsia is happening instead of who's at risk or who's not at risk? And preeclampsia causes a problem because it destroys blood vessels and because it compromises organs, but also because it prevents people's ability to adapt to all the other changes in pregnancy, right? All the fluid and all the volume you build up during pregnancy, when there's a malfunctioning placenta, you don't accommodate that as well. So we can start to look at things like the overload from not accommodating or the actual factors that are being released. And then when we start to understand that, we can look at more targeted therapeutics, right? Maybe we can come up with immunologic drugs that can suck up those maladaptive factors or things that can help process the extra fluid. Now, before I get into kind of the management innovations and touch on that, I think it's really important to just quickly review about the fourth trimester or after pregnancy. I call it the fourth trimester danger zone. And to understand that, I need us to kind of set the stage and understand what's happening in the US, right? The United States, for those of us who don't know, is in a maternal mortality crisis. Maternal death rates today are higher than they were 40, probably 50 years ago now, which is more than you can say for almost any other health condition in modern day. And when you look on the graph at the right, with the US line on the top and similarly developed high income nations at the bottom, we're also faring far worse than other similar nations. On top of that, we're starting to see a pendulum swing, right? We've spent so much time trying to understand preeclampsia in pregnancy that we are now seeing a shift to the deaths after delivery, right? And I can say that for a number of other health conditions too, probably. But what we're seeing in recent years, and this number is true today, I think there were recent statistics that come out, is that more than 50% of deaths happen after birth. And for high blood pressure, which is one of the leading causes, over 70% of those deaths in that spectrum we talk about are happening after pregnancy. 70% of hypertension-related maternal deaths are happening after delivery. And I'm going to rattle off what I think are four of some of the top reasons why we're seeing that, right? One, it takes time to go from being pregnant to not pregnant. We all know that you pop out a baby and your body doesn't go, I'm completely adjusted back to being non-pregnant. There's a lot of fluid you have to process and get rid of. All those factors from the placenta still have to be gone. And in the time that's happening, we traditionally had one visit for people at 6 weeks. Now there's some, updates and recommendations to try to do maybe 2 to 3 visits for high risk people, but still that's compared to weekly visits at least before delivery. And even if we add on to those visits after delivery, the fact still remains that follow-up rates are really poor, right? 40% of people don't follow up for their postpartum visit. That's even when we had one postpartum visit. And that number is higher for more vulnerable populations, socioeconomically vulnerable, language-wise, financially, et cetera. And remember I said 70% of hypertension-related deaths happen after delivery? Another really important statistic I really hope you leave here with today is that of those with postpartum preeclampsia, anywhere from 1 to 2/3 had no blood pressure issues before delivery, no signs that we knew of preeclampsia, right? So focusing on people who had hypertension or preeclampsia during delivery, you would think might be an adequate solution, but is leaving a lot of people vulnerable. So when we look at management, we really have to rethink who we're targeting and take an all approach situation. Now, when we look at some of the management innovations, part of the problem after delivery is there's so many competing interests in a system that's not built to support people. Transportation, childcare, work obligations, which you can imagine are even more prominent for people who are vulnerable, especially socially vulnerable. And so there's some innovations in digital tools that can potentially help, right? They can be expansive, smartwatches, smartphones, telehealth, et cetera. But we need to start to explore equity in the use of these. Again, a note on when we look at the maternal mortality crisis and compare the US to these high income nations, what are some of the differences we see? The workforce in the US for healthcare providers is not only far less, but I want you to pay attention to the ratio of OBGYNs to midwives. Far fewer midwives than all these other nations. Also, the only high income nation without paid maternity leave. Only high income nation that doesn't cover postpartum home visits. So I think a major innovation is reimagining care. I don't think we have time to get into what we're doing at UCSD, but I'm happy to chat about more if there's questions about our new strategy about co-locating health services and creating a postpartum home where they have a full spectrum of services and monitoring and closer visits. And one final word on that, I think it's important to recognize that whatever we can do in pregnancy, even if we extend it to postpartum, pregnant people are valuable clearly beyond their pregnancy carrying capacity, right? And preeclampsia and all these changes we're talking about can affect people throughout their stages of life. So everything that's happening here can affect people not just through 6 weeks postpartum, through a year postpartum, which is where you see a lot of the maternal mortality statistics rising, but for the rest of their life. So part of reimagining care and innovations, I think I would be remiss to say, has to include transitions of care from maternal providers to those who are going to care for people for the rest of their lives. And so I look forward to the questions that we're going to receive and talk about during the Q&A, and I thank you for your time.
Thank you so much, Dr. Meriwa. Please note for those that are watching live, you can submit questions at any time using the question and answer function, and we will try to address as many as we can during the panel discussion portion of this event. Next, we will have Dr. Kyle Weiner, who will discuss innovations in preeclampsia diagnostics, including prevention and high-risk reduction diagnostic strategies. Thank you, Dr. Weiner.
And thank you so much for the society's activities, and in this particular place, shining a light on a problem that is just not changing. I also have to start off and say very clearly, I'm a co-founder of NALA-DX, which controls the intellectual property necessary to perform some of the screening tests to be discussed. Early to extreme preterm birth, and by that I mean 32 weeks and less, is a massive unsolved problem. And there are two main causes: early onset preeclampsia, or EOP, occurring with delivery prior to 34 weeks, complicates 0.8% of US births. Spontaneous preterm birth, 32 weeks or less, complicates another 1.8% of US births. And guess what? This is a huge economic cost. Over 80% of direct medical costs in the first year of life are spent to support these preterm babies. And what are we doing about it? Well, we have an inefficient screening based on clinical and demographic variables with no personalized risk estimates. Not surprising, as we just heard, the US leads high resource countries in both spontaneous preterm birth, 32 weeks and less, and our rate of EOP is actually growing. Clearly, there is an unfulfilled need for a simple and accurate test to both identify and motivate. And what makes it more frustrating is that preventative therapies for women demonstrated to be at high risk have been validated over the past 10 years. Start off with early onset preeclampsia, delivery under 34 weeks. It is 150 to 160 milligrams of aspirin started before 16 weeks. And when that's done, you can reduce early onset preeclampsia by 82%. And that's a number based on over 200,000 women. The best results occur when initiated under 14 weeks, taken with high compliance, and dosed at night. And the same treatment may actually reduce early onset growth restriction, but it has no impact on spontaneous preterm birth, which, now that we bring it up, women with low RBCs, DHA levels treated by 16 weeks with 800 to 1,000 milligrams of DHA have a 48% reduction in spontaneous preterm birth under 34 weeks. And with high compliance, the reduction is 65%. Women with average to high baseline RBC DHA in the first trimester have the lowest rates of spontaneous preterm birth, regardless of whatever dose they're placed on. Well, how do we identify at-risk women in the first trimester? And here our options are limited. The best screen for early onset preeclampsia, less than 34 weeks, was developed by the Fetal Medicine Foundation. It is a composite test that is run at 11 to 13 weeks, but has a detection rate of 88%. All the other preterm birth tests are run at 18 weeks and higher. Which brings me to liquid biopsy, plasma transcriptome. In the last 25 years, there are more than 1,500 discovery type RNA studies of multiple diseases. There's even over 200 published studies of RNAs and preeclampsia. And yet, there are 0 tests in clinical use. And that's because there are 0 tests that have survived repetitive external validation necessary for deployment. You have to be able to show a test works in multiple populations. That was till recently. In 2021, we presented a paper in the British Journal of a group of plasma RNAs predictive of spontaneous preterm birth under 32 weeks. And just briefly, this panel of 5 differentially expressed RNAs were selected because they interacted with 7 myometrial initiator genes, genes that were only altered in early onset preterm labor. These RNAs actually increase smooth muscle intracellular transport, which increases cell contraction frequency. And we know that these RNAs can target specific cell types, but this is not determined by the RNA, but rather by their extracellular transporters. And though considered unrelated, I find it interesting that spontaneous preterm birth and early onset preeclampsia share abnormal smooth muscle activity. So that brings us to validation studies and what they need to look like. And here is the series we have published. The first one was with the British Journal, a simple case control, small, it was perfect, and we all know perfection is not part of biology. But a year later, we published a 305 pregnancy cohort sample. This time they were sampled at 16 to 20 weeks. And what you can see is when you use the RNA panels, their history of prior preterm birth, and race, you come up with an area under the curve of 0.83, which is a good test, and a detection rate of 77%. Move on to the following year, and what we have is a study of 60 nulliparous women sampled at 12 to 13 weeks. And you can see using the same panel and then some information that was provided to us by the Fetal Medicine Foundation, you see an area under the curve of 0.79 and a detection rate of 79%. Now, to go back to the 305 cohort, while we were doing that early analysis, we noted that women with early onset preeclampsia seem to have overexpression of different markers than the women who were at risk for spontaneous preterm birth. And in this publication in 2022, you can see that combined with the RNA panel and parity and the mean arterial pressure, we had an area under the curve of 0.96 and 100% detection. Fast forward to the SRI this past year, where we presented our next cohort of 494 women. This time they were sampled 12 weeks to 20 weeks, and 21% of them were sampled under 14 weeks. But when we broke the diagnostic codes, we found out in this whole cohort, there was only one woman who had a delivery at 32 weeks or less. So looking only at early onset preeclampsia, what we could see was the same RNAs, mean arterial pressure, this time had an area under the curve of 0.89 and a detection rate of 89%. Interesting, there were 2 women sampled under 14 weeks who developed EOP, and they were screened positive. Also interesting, there were 2 subjects who were placed on low-dose aspirin under 14 weeks, and they were both screened false positives. So our collective failure to understand the rate of early and extreme preterm birth reflects a lack of understanding. The fact that 85 to 95% of women destined for EOP and delivery under 34 weeks and 80% destined for spontaneous preterm birth 32 weeks or less can be identified by 12 weeks strongly suggests these diseases originate in the first trimester. And treatment to prevent disease is more likely to be successful if it is initiated early in disease development. And if prevention is to be our goal, to reduce the number of women at risk for illness and death, well, then EOP and spontaneous preterm birth require separate, accurate, and early pregnancy identification as the therapies that are effective to block the diseases are different. You know, the World Health Organization says there is over 2 million babies delivered 32 weeks or less worldwide every year. If each of those babies has a mother and a father, that's 6 million people whose lives are changed by disease that we should be able to prevent. If they have one sibling, that's 8 million people. How often is there an opportunity to change the lives of millions of people annually? I think that with liquid biopsy and continued research, we are on the cusp of that. So I thank you very much for your time and look forward to the panel.
Thank you so much, Dr. Weiner. Again, I invite you both to turn on, Dr. Emerua, to turn on your camera. And for those that are attending, we invite you to submit questions using the Q&A function in the app. We will try to address as many questions as we can in the remaining 10 minutes or so of the program. Please note that our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for personal medical or professional advice. We encourage all patients and consumers to confirm their information and consult with their healthcare provider to determine their individual needs. And so to open up this conversation, one of the things I really appreciate about both of your talks, they highlighted this idea that there is this, the causes of preeclampsia are multifactorial. And it's not just an issue of I'm doing too much salt, I'm gaining too much weight, and it's this behavioral blame on pregnant populations. And so while there's certain things that we can't control and there's certain modifiable risk factors and things that we need to be cautious about, what should healthcare providers help their patients better understand about their future health after pregnancy with preeclampsia?
Yeah, I mean, I can
Mhm.
jump in quickly. What I, usually say is I try to briefly allude to this, but it's not modifiable in terms of who gets it, because if you have a placenta, you can get it. Although the healthiest version of yourself, the less susceptible you are to being affected by it, certainly helps. So like going into pregnancy, the healthiest version of whatever your health status is, you can achieve, improves it. But like I said, because there are actually so many circulating factors, proteins that are affecting blood vessels, affecting organs, even when you go back to a non-pregnant state, you're still changed, right? Everybody says, even socially, I am a new version of myself now that I've had a child. Your body is that same new version of yourself. And when it has demonstrated that it can be or has been impacted by these things, that's very meaningful for long-term health. People with preeclampsia have higher rates of cardiovascular disease and other heart attacks, other complications, whereby if you ignore it and let it go until that thing happens, we've missed an opportunity to improve where you can, right? If we stay on top of our health, once we've shown what our body can do, say, oh, this is my opportunity, even though that wasn't my fault, to make sure that I set myself up to be healthy and don't allow it to affect me long term. So I try to make my patients very aware of the long-term risk so that they feel like they have agency in preventing those poor outcomes that could come.
And Dr. Weiner, many innovations originate in these diagnostic space, they originate in academic research settings. But maybe can you speak to some of the challenges that hinder moving these advances into widespread clinical use? Because I know you mentioned there are limited opportunities. And there's a question as well to dovetail talking about the liquid biopsy technology and its use and the availability. And so how can we, like, what are some of those key challenges and how can we reduce or eliminate those barriers?
Boy, if I had the answer to all that, it would be wonderful. So, first of all, it is clear that our rates of preeclampsia are increasing. And therefore, there is something changing in our society. Um, I just wanted to say this. I think we do a terrible job with treating diabetes and hypertension, especially in young patients who don't even know or don't believe they actually have hypertension. And we already have trials showing us that if we control that chronic hypertension better, the pregnancy outcomes are much better. So we have some gaps in our behaviors. But moving over to diagnostics, it has been a long road. I think many of our diagnostics that became available and ultimately faded away focused on predicting problems in the mid to late second trimester. So the timing of what we studied was probably too late to make an intervention that would appear to change outcome. And I think we're seeing evidence being published every so often of that there. We know that at least with the plasma transcriptome, I'm not talking about the proteome, but the transcriptome, that these differentially expressed RNAs appear to be from the placenta. And I didn't get a chance to say that, but they are way high in the placentas of women who have these complications. So it makes sense that this is a placental disease. We also know that early in pregnancy, the disease looks very different than it does either after the onset of symptoms or shortly before the onset of symptoms. So I think one of the challenges for the people who have taken the labs over from old people like me is to look early in pregnancy. And that's a little more work because you have to be more organized. You need to get your samples. You need to be able to follow patients. But then that comes to the funders of the research. And right now, I think we as a group of practitioners can do a better job trying to monetize how much money it either costs not to do this research or how much we save by doing that research. And that opens the door for anyone who has any interest in doing research on pregnancy related diseases.
Thank you so much for that. Dr. Amaro, did you want to add to?
Yeah, I was just gonna piggyback on the comment about, additional pressure and kind of a plea to funders. I think part of it is also saying, to your point about all this happens in academic centers, and then we say, okay, well, what about the vulnerable populations who are removed from those academic centers? And I truly think it should be almost a requirement, right? To say, if we make it so that you have to partner with rural settings, rural centers, me, I do global work, global centers to demonstrate these outcomes in different populations, you probably will even see that, again, technology and innovations can widen disparities, but when you approach it equitably from the start, I think it can be really profound how you see it can close gaps and close disparities. And if we almost made it a requirement that you have to step outside these academic centers to include these populations. And we showed the significant closing gap in these outcomes. We can have something more quickly like cell-free DNA, or that, looked for screening for Down syndrome, that used to be for very select high-risk populations, and now it's almost everywhere, at least in the United States. If we include that from the beginning, that can become a standard going forth, and these technologies become less and less expensive.
And so we have to wrap, but I had one quick question that I wanted you to just touch on because I saw someone had submitted, are these rates of preeclampsia seen outside of the US as well, or is this more of a global north issue?
Dr. Weiner, you want to tackle that, or should I chime
No,
in?
I can tackle part of it. It depends where in the world we are talking about. So there are significant variations in total preeclampsia among countries. When you look at early onset preeclampsia, the variation shrinks, but there are still some countries with much higher rates. And if you were to guess, and you said, well, I think there are probably countries with lower resources and not active diagnosis of chronic hypertension or diabetes, which in my mind are probably the two major causes. They're not worried about them in those countries. And unfortunately, the graphs that were shown are just are true, and that they could even exist in the United States is a shame. It is a shame. But
I think
yes, it varies, but the reason for variance can be understood.
And I think on the high end, there are some developed or resource limited areas where the rates are as high as 25, 26%, right? And so I think, to Dr. Weiner's point, part of it is if there's less support for chronic disease management, that probably contributes. We do have insights that there might be genetic variation, right? ApoL1, which is a gene that affects kidneys, is starting to be linked to the onset of hypertension, which is probably linked to preeclampsia. That's more common in, for example, like West African regions. It has protective mechanisms elsewhere. So maybe there's some genetic variation. There's probably some social stressors, which we know affects cortisol levels, affects people's access, can also affect their susceptibility. And finally, I think what it really highlights is exactly what we're seeing in the postpartum setting. When health systems are set up well to capture and manage these things, we see lower rates. In the US, we see a case study where after delivery, our health system completely breaks down for support, and we're seeing mortality from hypertension skyrocket. And so in places where health system support is not robust, I think we're just seeing that across the board during pregnancy and after, and that also probably contributes.
Thank you so much. I know we have a bunch of questions that, I had, and there's some more, but I know we have to wrap up with time. But I do have one last question for each of you to briefly comment on. We have diverse audiences spanning patients and healthcare providers, as well as researchers, industry, and policy professionals that tune into our online events. And so, what is one key takeaway that you would like to emphasize? And Dr. Merua, I would ask for you to address the researchers and clinician scientists. And then Dr. Weiner, if you can, for women and their families that are planning or building their families. So we'll start with you, Dr. Weiner, and then you, Dr. Emerald.
Yeah, I think thankfully a lot of researchers and clinicians, or most of us, are starting to step back from just categorizing it high blood pressure. So like I said, shifting how we define it in our heads. And to Dr. Weiner's point, shifting from how we're picking it up close to delivery when it's already taken effect, to really understanding it to the degree where we can pick it up and then even start to prevent or treat it before it gets to the point where it's impacting all organs. And I think, to add on to that, like I said, doing it in a way that does not neglect variable populations, because we've seen how biologically, socially, genetically, health system wise can play a role in this. So it behooves us to include very diverse populations as we're studying these things, so we can look at it from the onset and improve everybody's health equitably.
Awesome.
And I would agree with that. But we live in a society where we're retracting. And so we need to find ways to make healthcare available before pregnancy, so we don't have so much unrecognized chronic hypertension that shows up suddenly. Oh, she's got early onset preeclampsia because her body's following the normal physiology. So if we had clinics with midwives, nurses, who women could go to, if only just for hypertension and diabetes, the impact would be massive. It really be massive. Because I work in a number of different hospitals these days, and I see this over and over again. And we have to do a better job of that. And then we have to prevent, we have to find a way, and we have to use the therapies we have now. Not saying they're perfect, but they're better than having a woman have a stroke at 26 weeks of pregnancy.
Thank you so much. You guys have been an amazing panel, and we really appreciate the time and insight that you've provided to this program. We also thank Roche for their support of this public forum and SWHR's value of diagnostics within women's health series. And then we also want to thank everyone in the audience for joining SWHR during this diagnostic series, where we're highlighting various areas of women's health that benefit from innovations in screening and diagnostics. I'm glad it came up quite a few times, the diabetes and the gestational. So you see in November for Diabetes Awareness Month, we will be hosting a webinar in this series focused on gestational diabetes as well. And so we invite everyone to visit our website, www.swhr.org, to watch the recording from this particular webinar, as well as from the entire series of public forums, and keep an eye out for this upcoming gestational diabetes webinar. Understanding women's health and their individual experiences and health journeys really helps us inform healthcare systems and policymakers on critical gaps in specific areas of need in women's health. And so SWHR invites you to share your story about maternal health, fertility, heart health, autoimmune disease, or another women's health topic by visiting swhr.org/share your story. And so I think they will drop that in the chat for those to click that link. In addition to our website, you can also connect with us on social media to register for future events, download women's health resources like our fact sheet on diagnostics for preeclampsia, and to sign up for our newsletter. We will send out an email with the recording of today's webinar to all registrants, as well as post a recording on this event's webpage for future viewing. So please be on the lookout for that, and feel free to share with others as we continue the very important conversation with hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Maternal Health. Thank you for joining us.